Okay. So we talk about collaborative care for septic shock. Okay, so we have our protocols in the hospital. Again, we're going to fluid replace. We're going to restore volume. We're going to have our CVP between 8 and 12. And we can give to 6 to 10 liters of fluid. That's a lot of fluid, right? And again, once we have our fluid on board, we may give vasopressors if we have to, and they're still tanking, and we'll give vasopressors, such as norepinephrine or Levofed. You ever heard of Levofed? Very dangerous drug. Again, with sepsis, sometimes they will give corticosteroids, sometimes for hypotension. Antibiotics, like we talked about, after blood culture, stat, right? Again, our antibiotics are started within the first hour. We go from broad spectrum, then more specific. We can add a H2 blocker. I know my doctor gave me Tagamet, and that helped with the reaction and the symptoms. And of course, medicine to also prevent stress ulcers, like PPIs. We want to give them DVT prophylaxis, SCDs, right? Sequential TED stockings, if they need to have those. We may put them on isolation, reverse isolation, if they're immunocompromised. We're going to take a break after this, guys, okay? I know it's a lot. So, collaborative care with obstructive shock. So, identification of the problem is really key here. Treating, we may have to do like mechanical decompression, radiation like we talked about, or removal of the mass. Sometimes they call it a decompressive laparotomy. They may treat pericardial tamponade. They may take a needle and aspirate, or they may, like I said, open up and do open heart surgery. We're going to treat our tension pneumo, if that's the cause, with what? Chest tube. Good. Chest tube, right? Or hemothorax, if that's the cause, chest tube. If the cause is a PE, we're going to give thrombolytics. If we have the SVC syndrome, like my patient had, we may have to remove the mass. That's the only way to resolve the problem. So they may need emergency surgery. And the same for abdominal compartment syndrome. If all that fluid's building up and blocking off vessels and arteries that can go back to the heart, that's really the problem. Evacuate it. You got to evacuate it. Open them up and do surgery. Again, treating the cause. So for all shocks, what's our nursing diagnosis? Good, right? Ineffective tissue perfusion. You can get more specific into the organs. Okay, cardiopulmonary, GI, hepatic. Anxiety, definitely. Any of you other think of anything else? Yeah, could be tissue perfusion, but we can make it more specific to the organs for sure. So basically, that's for your shocks. But yeah. Again, we talked about assessment, so this is just a review again. ABCs is always priority, right? Airway first. Circulation, right? So we're getting vitals, peripheral pulses. We're assessing level of consciousness, cap refill, urine output, skin. The history, we need a good history. Onset and duration of symptoms. How long ago do they start? What is their past medical history? We want a story. We want to be very well informed And the more we know, the more we can relate to the providers, and the more appropriate care we can get for our patients. Again, our goals. What are our goals? Perfuse our tissues, right? Adequate perfusion. How do we know that our treatment is effective? Good. But how do we know that? What are we looking at?
You look at vital signs.
Vital signs are normal now, right? Yay, we saved them. Back to baseline. Our rhythm is a beautiful sinus rhythm, right? Recovery of organ function. How do we know that? Labs, good. Maybe our BUN and creatinine are now normal, right? So labs will normalize. Our hemoglobin, our hematocrit will be stable. So that's what we want to return to normalcy. And we're going to avoid complications. What kind of complications can happen in the hospital? Infections, right? The most common thing are hospital-acquired infections from lines, central lines, catheters. We want to be sure we are using very, very strict aseptic technique with all of our lines. Of course, we're identifying our at-risk patients, like we talked about before. Prevention, hand washing, hand washing, hand washing. Okay. And watch for subtle changes. Sometimes changes in mental status can be very subtle. So we're watching for all those little subtle hints. Sometimes it just doesn't come out to bite you, but you can kind of see your patient kind of slowly declining. I know one time I was on an open heart floor, and I had this patient, and he was 92, and he had open heart surgery. And I knew, like, the day I had him, he walked up and down the hall 3 times. He got himself in the bed. The next day I came in, and the nurses were lifting him in the bed. And I said, "Is this the same patient?" He couldn't walk 2 feet. And I said, "Something's up." I knew something right away. I knew something was wrong with him. I looked at his EKG. I saw a widening QRS. I took his blood pressure, was starting to get hypotensive. His SAT was dropping. I called the surgery. I said, "You got to come back and take him into surgery." I knew he was tamponading. And sure enough, he was tamponading. And they worked on him all night. And they did actually save his life. He recovered. But he came back from CSICU, and the first thing he said to me is, "I wish you never did this." And it broke my heart, because he had to go through open heart surgery a second time to fix his tamponade. And he was 92. But he didn't tell me at the time, "Don't do this," But then, a couple weeks down the road, he showed up behind me, maybe 2 weeks down the road or 3 weeks down the road, and he was wearing a little volunteer outfit with a little heart pillow. And guess what he did after that? He was a volunteer. And he came to encourage the patients not to give up. So it was a nice story. And I still have the letter that he wrote me. So you just have to kind of use your judgment and how to help these people. Go by your instincts. If your gut's telling you something isn't right with this patient, you need to go with it. And the doctor said to me, "Amy, why are we all here?" And I said, well, there wasn't really a whole lot I could tell him. I'm like, well, he couldn't walk down the hall. He couldn't get himself into bed. And then he's like, what? And then I gave him more specifics, and he said, okay, I'm putting the picture together. And I was that patient advocate, even though I couldn't really tell him, but my gut was telling me something was wrong. And, of course, I backed it up with what I thought, vital signs and rhythm and so forth. But it shows you your gut is right, and you should follow your gut. And if something's telling you something isn't right, you're not getting a blood pressure, you're not getting a good temperature on a patient, they're having mental status changes, and you know your patient, and you may get pushback from physicians or ICU nurses or wherever you are. But I can tell you, it's their life, and their life is worth saving. And you can go home and knowing that you did everything you could for your patient. And that's really what matters. Okay, so we want back to baseline. We want our EKG normal, we want our blood pressure, our CVP normal, our PAWP normal. We want warm and dry skin. We want urine output. We want our SATs good. Our level anxiety goes down a whole lot, right? When we're feeling better. Normal MAP over 65. We want our CVP between 8 and 12. Our lactate levels will normalize. Okay, and we're going to document all this too. Right? In your spare time. All right. Yes, sure. Yep. I'm going to stop my recording. Does anybody have any questions?